Okay, I think we are live. So welcome everyone to our second afternoon Ask the Docs panel with a focus on research questions. We are going to be monitoring the chat feature for questions. So if you have questions, please, you can type them or ask a caregiver to help type in any questions that you have into the chat feature. We're not going to be looking at the Q&A tab, so please put them in the chat. We'll begin with introductions. So if I could start with Dr. Benatar, please.
Hey everybody, I'm Dr. Michael Benatar. I'm a neurologist at the University of Miami, where I run our ALS center with a heavy focus on research. And I apologize to everybody that I'm in a t-shirt today. I'm on vacation, but this was sufficiently important that I had to be here. So I hope you forgive me.
That's wonderful. You can even have a cocktail in your hand if you'd like, Dr. Benatar. We appreciate that. Dr. Gooch?
Yes, I'm Dr. Clifton Gooch. I'm chair of neurology here at the University of South Florida and vice president for research at Tampa General Hospital. I've spent much of my career focused on ALS research along with the other distinguished colleagues here in the room.
And Dr. Locatelli.
Good afternoon. I'm Eduardo Locatelli. I'm the director of the P.L. Smith Neuroscience Institute in Fort Lauderdale and co-director with Lauren Gray Ortega of the Center of Excellence for ALS.
I'm Björn Oskarsson. I'm a neurologist here at Mayo Clinic in Jacksonville. I direct the clinic. I do both clinical trials and work a lot with our basic science researchers.
And Dr. Vu?
Hi, it's Tuan. I'm a neurologist here at the University of South Florida. I direct the ALS Certified Center of Excellence here at the university. I do a lot of clinical trials in ALS and other neuromuscular diseases.
And Dr. Weimer?
Yeah, I'm a James Weimer, a neurologist at the University of Florida. I'm also at the Gainesville VA, where I am the director of both clinics.
All right, and I'd like to say thank you so much to all of you for joining us. Important part of clinical care. It's a part of clinical care. While we're waiting for questions to come up in the chat, we did receive some questions that were submitted via our online registration forms. So let's just start with a question about clinical trials, about how many clinical trials are going on at any given time in your respective centers and how many are currently enrolling patients.
I'll go first. We have about 6 trials going on at our center right now. The platform is actually several trials in one. So in reality, we have more than that. We have a couple in the wings that's going to be coming online shortly.
Yeah, I think we can say, just to address that, this is an incredibly exciting time for all of us, because when you say how many clinical trials, we're all in the same situation where we're going to have 4 or 5 clinical trials active, but we've got 2 or 3 waiting in the wings that are going to be started as soon as those 4 or 5 are finished. So as far as actively enrolling, I think we've all got. The one thing about this is we all have diverse ones. We're all collaborating. We're working together to find who's going to be the best for which clinical trial to help out patients.
Yeah, I have to say that when we got offered trials, we tried to see how many patients we're going to be able to enroll. So we commit to enroll patients and not to overcommit to, because we got too many trials. So we've taken, make sure that we commit and deliver the enrollment that we promised the trials to receive.
It's a very different landscape compared to how things have been historically. The number of trials that are currently active is really unheralded. So it's an exciting time. And that's experimental treatment trials. I mean, much of the work still needs to be done for us to understand ALS. We might be able to come up with something based on our current understanding. But there's also a lot of work being done that is focused on trying to understand what ALS is. And while treatment trials are something for a portion of patients are able to kind of help us with that, pretty much everyone can help us try to come up with an understanding that leads to the cure eventually.
Right. And I would say, just to sum all that up for the viewers, that there are more trials going on now in ALS than ever before in the history of ALS, more clinical trials, and that every one of these centers has multiple trials and more coming. So that's the good news and kind of the summary.
And I was just going to add, at the University of Miami, in addition to participating in many of the studies that you've heard about, we're actually up and running with the first ever ALS prevention trial. And I hope I'll have a chance to talk a little bit about that during the course of this panel, but we're super excited about that.
That's incredible. So at our previous panel, where we were talking and focused on clinical care, Dr. Pulley and Dr. Granite did make a plug for participating in clinical research. You know, the elephant in the room is kind of that 2-year mark. So many people trials, but if they've had symptom onset or a diagnosis longer than 2 years, they often don't qualify, or other things prevent them from qualifying. But there are other kinds of research that can help. Can you all talk a little bit about those trials that others might be able to participate in?
I think like Dr. Bedlack said earlier, many of his trials have pretty liberal limits. And the current one that we have around the Annexon study is 3 years. The Hilly platform is also 3 years limit. And we're cooking a study using Fasudil, and we haven't set the particular limit yet, but probably going to at least 3, maybe 4 years. And part of that question is also which study allow no placebo or has no placebo arm. So the Refine ALS, which look at biomarkers, doesn't have a placebo arm. The Annexon study is also open label. And the Fasudil study is also going to be open label. And like I said before, many of the Bedlack studies are open label.
And Patty, if I could add, sorry, I have a lot of echo. I think we have this sort of constant sort of tension or challenge when we design an ALS trial, where as a community we've begun to have success. And I'm thinking of edaravone and potentially other new compounds coming down the pike, is enrolling people earlier into the course of disease. And so we have this tension of wanting to be broadly inclusive, but also knowing that historically we've had greater success in seeing efficacy signals when people with earlier disease participate. And so I think that tension is always going to exist. I think that's partly what's leading to some of the increasing interest in expanded access programs for people who don't fit eligibility criteria. But there's also very important work that needs to be done observationally in biomarker studies and genetic studies, in environmental risk studies. So even if you're not eligible for a trial, there are many other types of studies that you could participate in. And remember that we hope a trial will have a therapeutic effect, but it is an experiment. We don't know that. And the therapy may be harmful. And so you can participate and contribute to research and move science forward, even if not eligible for a clinical trial that's available to you locally.
And we all really have in mind, sorry for the echo, what Dr. Bedlack was talking about, that the idea is to get multiple studies at each center that will cross different segments. So we will have something available. Sometimes it's basic science related, but a lot of times we have a mechanism of action open label AMX study that we're doing, which has very broad inclusion criteria to get involved. So these projects that are involved in the science of how a drug works are ways to approach it. Our Metformin is another one of those. That's for a very particular population, but that's another one. How does the drug work, as opposed to does the drug work, or where, more particularly. So that's, as Dr. Benatar was pointing out, that's the importance of what we've always described as these science and care hub model, where you have centers that are able to bring a lot of these trials to patients to get them involved in clinical trials, in research, in basic science, and really drive the understanding of not just the therapies, but the disease itself.
And
I
I
want to
see
point
a
out
question.
the expanded action, if I may.
Yeah.
We were lucky with Dr. Bedlack and Mass General to participate in the expanded access program with CLEAN study, and it's an add-on program to the Healy study. To me, it's a great hope that maybe all the arms and many of these medications, if the patients do not qualify, that we can establish kind of add-on and piggyback to the studies to have the expanded access program for those patients that do not qualify to participate. This is the perfect example of the CLEAN expanded access program that is about to start next week. I wish we can have it for all the arms and for all the other studies. If the patients don't qualify, we can at least expand the access program globally, not just a few drugs.
Yeah, I think this is, I really want to focus on this placebo question and the trial question here. There's a question in the chat. Why would anybody want to join a study only to end up in the placebo group? Can you all talk a little bit about how trials are designed and how, you know, maybe ratios are designed so that more people can have access to the trial drug, and how pharmaceutical companies are aware of this issue and the fact that people want to be able to receive the treatment, and what is expanded access and open label, all that, what does all that mean?
That's a pretty broad question. I'll tackle some of it, and some of my colleagues may want to jump in. It's a common question, of course, and the other things you mentioned at the end are kind of separate but related issues. So let's start with the issue of placebo-controlled trials, because, you know, as a patient, of course, you have ALS, you want to get a shot at a treatment that may work for you. You know, that's your goal, number one. You also want to help to advance the science of ALS for others, but you really want to try to get a shot at something that may work for you. So why on earth does the FDA and all of us researchers talk about placebo-controlled trials and give our patients, you know, a chance of getting a placebo? And it's because of something called the placebo effect, which many of you are probably familiar with. So the placebo effect on average across all clinical interventions, and that could be surgeries, or it could be sham surgeries, or it could be drugs, it could be devices, it could be all kinds of things. It's 30%. So is that just people feeling like they feel better? No, not necessarily. In fact, with the placebo effect, we can actually see improvements in function. Sometimes we can see physiological measures improving just based upon the placebo effect. So that is something we don't fully understand as medical scientists, but it's been recognized for a long time. It's mind over matter in a way. And but it does mean that if we want to know whether a drug really truly works or not, we've got to account for that. And the only way we've been able to figure out how to account for it, at least the best way up to the present time, is to match patients as closely as possible in terms of their disease characteristics, stage, and everything else, and put very close to identical patients in a placebo group and a treatment group and compare and see if the treatment group beats placebo or not. Because placebo does work to some extent. And so that's part of the problem. Now we're trying to innovate new ways of dealing with placebo. For instance, there's something called the natural history control, where you but this takes a large group of patients, generally speaking. Take a large group of patients, you put them in a treatment trial, you take your historical data about how ALS patients do from databases that we've constructed over the years and try to compare those head to head. And that is one approach. It's not an approach that the FDA is terribly fond of because it's not quite as robust proving that a drug works as a placebo. For patients who don't want to participate in a placebo-controlled trial because they don't want to take that chance of getting a placebo, I think there are a couple of considerations. I mean, one thing is there are some trials that will enable you to take other agents that are proven to work, or FDA approved anyway. So riluzole is one of them, of course, that we have to account for frequently. And more recently, edaravone another, Amylyx maybe another. Many of the trials are designed so that you can get those treatments and still be in a placebo limb, so you're not getting nothing. So that's something else to consider if you're a patient. If you want to, go after some other experimental drug, as has been mentioned already in this session, you can look for trials that are what are called open label, that don't have a placebo-controlled limb. Those trials are out there. Or as with Dr. Bedlack's talk earlier, you could go, try something outside of a traditional clinical trial and try to put together some of your own treatments with your physicians, or join one of the trials that he talked about. So there are avenues for those who don't want to participate in the placebo-controlled trial. It's an individual decision that everyone must make. The patients, you have to sit down, yourself and think it through and decide what you want to do. There are other advantages to being involved in a clinical trial, even if you're in the placebo group. When we look at placebo groups in these trials, patients in placebo groups in clinical trials, and this is not just ALS, but it's other diseases too, even outside of neurology, cancer and other things, they do better than the average patient. And part of that may be the placebo effect. And part of that is that they get a lot of extra attention and they're seeing their doctors and their teams much more frequently than other patients might be because they're being assessed for the trial. And that helps with their care. So there are benefits actually to being in a placebo limb of a trial, even if you're not getting the active agent. The other flip side of that is it's an experiment, as Michael said. So it's possible that some of these drugs could hurt you. There's a risk of that. We try to minimize that risk, but it's always possible. So if you're in the placebo limb, advantages are you may get some placebo effect, which can actually be physiologic in some cases. You're going to get extra attention, which is probably going to prolong your life and help you get even better care. And you're not going to be subject to the side effects of the drug, whatever they may be. But again, I understand how some patients might not want to go that way. So it's a personal decision. So other folks may want to chime in.
Yeah, I guess I would just add to that, Cliff, that if we didn't have placebo-controlled trials in previous studies, we wouldn't have a sense as to which drugs work and which drugs don't. And so, the unfortunate reality is that that's the best tool that we have to figure out if something works or doesn't. So if we hadn't included placebo groups, we wouldn't have the few somewhat effective drugs that we have. And we'd also have tens or dozens or maybe hundreds of drugs that people might be taking in cocktails that we don't know where to help and that might be hurting. So I think every individual has to decide, as Dr. Gooch says, whether you want to be in a placebo-controlled trial. But one way to look on it is if there's a one-to-one randomization. If you're not in a trial, you have a 0 chance of getting the experimental drug. If you're in a trial with a placebo, you have a 50% chance. So that's perhaps glass half full, half empty perspective, just a different way of looking at it. But I do hear and appreciate the challenge.
I think all of us who do trials are very mindful of this. It is a complex question. We do need the placebo to see anything but pretty much a cure. If for drugs that are so potent that they actually would reverse ALS, yes, we would not need a placebo there to kind of perceive the effect. But for most of the things we are looking at here, we really do need that. There may be particular drugs for these genetic forms and such where we maybe have drugs that are so powerful that one could consider other designs. This is a constant dialogue as we design trials, kind of how can we make the best possible experiment. And a study that patient wants to sign up for is a good study. Studies that patients are not interested in signing up for are less good. We want to bring patients in as quick as we can, fill them up, and get the results out.
And if everyone could mute their microphones when they're not speaking, we're getting some feedback.
The only thing I want to add to this comment is, when I mentioned this, is we not only have to prove the medication works, but we have to convince the government that it works. And right now, the FDA requires these models to approve the drug because ultimately the drug works. The FDA needs to approve it, and then the insurance and Medicare will pay for it. So until they decide that they don't need placebos, then we have to get these placebos so they are convinced and they actually end up paying for it. It will be useless if they don't pay is another challenge. So until then, until the FDA requires no placebo, we're going to have to deal with that technical aspect of the government.
Well, you've given us an important topic, and I appreciate your comments on it. I think it really does need to be addressed, and it's something that is very meaningful to people. So we do have a question in the chat to comment on stem cell therapies. It seems like the stem cell trials that were going on were sort of the hot topics of ALS research. What's the status of stem cell potential as a realistic therapeutic agent?
So we are still conducting our mesenchymal stem cell project. It's a project we run at Mayo for 7 years. Again, stem cells are not one thing. It's sort of like you say, medications. There's no end to the number of cell products that we can come up with. So again, it's a eventually we would expect that cell therapy will be a very useful thing in helping us regenerate the nervous system. The things that, for example, we are doing with mesenchymal cells is far from that. I mean, that is not a truly regenerative therapy. That is a cell type that cannot turn into nerve cells. It's a cell type that may have other benefits, but again, it doesn't regrow nerve cells. The one we are doing is, again, one where we deliver a product in the spinal fluid. It's a cell type that has an ability to kind of move through the spinal cord to where we think it needs to be. There are other attempts of actually injecting cell types that don't have that kind of ability to move through tissue into the right place. Many of the current cell therapy products are aimed at delivering a drug or a growth factor to the motor nerve cells. Again, not truly regenerating nerve cells. So we're definitely learning more about cell therapies today. There are many active projects. It is a space that is also marred by some non-serious actors, I would say. So that's something to kind of look out for there. But we're definitely advancing, and it is for the future.
Second that last statement there. Please, I would urge all the patients, if you're going to get involved in stem cell therapies, please seek out a legitimate center and a legitimate stem cell trial. There's a lot of flimflammery and, frankly, a lot of con artistry and fraud going on in this space, not just in neurology. So you have to be very careful. They can, if you get in the hands of a wrong physician, you can get infections, you have other problems, you can lose a lot of money. So please, if you're going to pursue it in a legitimate center that is doing legitimate work and research and not from some off-color place.
Yeah, that's perhaps
Aware that being involved in a stem cell trial may also exclude you from being involved in other clinical trials. So really, before you get it, it should be a discussion you have with your neurologist.
And perhaps the other thing to say is, I think for whatever reason, I think there's some mystical aura around the term stem cell, that somehow we imagine this maybe because it's stem cell. I don't know, it's got an origin where it can do anything. We have this sort of magical belief that a stem cell is sort of a magical bullet. And I think for now that's unproven and unestablished, and there are many reasons why that's not going to be the case. Not least of which is what kind of stem cells, how to modify them, where to deliver them, how frequently to deliver them, what is their potential. So I think these are all things that are unknown, but somehow there's this sort of glow and this aura around stem cells that I guess baffles me a little. It's an area that needs to be studied, but we don't yet have stem cells as a therapy for ALS. And anybody who tells you that they have a therapy with a stem cell, that's not legitimate.
My little experience with a patient that participated in such a trial, they tend to be some of the most aggressive studies. Bone marrow aspiration of stem cells is very painful. Lumbar punctures to inject the stem cells can cause headaches and vomiting. So they're not benign studies to participate, particularly if you're going to have a placebo arm. So again, I echo James Weimer, discuss this with your neurologist, because they're not the most easy studies. So they're really, even the placebo can give you a lot of problems in side effects and in other arms. So they're really attractive in terms of the aura that Michael is talking about, but they're really rough studies. They're not so easy. So discuss this with your neurologist. I strongly recommend that as well. Good point, James.
Okay, and there's a question in the chat that says, what is the state of the art on using electrical current to improve neuromuscular functions related to ALS or neuron signal pathways within the brain? Does anyone have a comment on that question?
Well, we have a couple of electrophysiologists on the line. I think everybody does EMG, but I think Michael and I have both done a lot of research in electrophysiology. I'm going to throw that one over to Michael, and I might add a comment or two.
Yeah, so I certainly won't claim to be the guru, but what I would say is that right now there is no evidence that electrical stimulation is somehow neuroregenerative or is going to have an effect on slowing the progression of ALS. I think we use electrophysiological or electrical techniques as part of the diagnosis and as part of biomarker development and trying to monitor response to therapy. And we use these in preclinical models as well as we're trying to figure out if drugs might be effective, but this really is not a therapeutic per se.
Right. I think there's a lot of confusion about what physical therapists sometimes do, which is peripheral nerve stimulation to build up muscle bulk. That is a technique that can work, especially after orthopedic injury with some nerve injury associated, say, with a knee replacement or something of that nature, where the nerve is expected to come back and the nerve itself doesn't have an underlying disease. It was damaged mechanically in the course of the procedure. And you can then, help to preserve muscle tone and things of that nature. Whether or not this kind of peripheral electrical stimulation of the nerve it's really just exercising the muscle is what it's doing continuously to kind of keep muscle tone going is terribly beneficial for ALS patients, more so than, say, standard physical therapy and exercise. It probably is not much more helpful than that, although I've seen folks use that, especially for foot drops sometimes. Is it deleterious? Probably not deleterious. At least it's unlikely to be very deleterious, but I think, it's probably not more helpful than standard PT. When it comes to the central nervous system, we do have techniques now for stimulating the central nervous system through the skull, transcortical magnetic stimulation. We don't yet know whether it's possible in the case of ALS, where the underlying problem is that neurons are being damaged, to somehow revitalize them or make them more healthy or slow disease progression by continuing to make them fire. There is an argument to be made that you could make things worse that way by enhancing this thing we call excitotoxicity. And so you have to be very careful, I think, about experimenting with transcortical magnetic stimulation techniques or any CNS stimulation techniques in ALS. So I agree, there's probably not a big indication for that particular approach in ALS, in my opinion.
I would kind of also bring something up there. There's some studies that we did a while ago, the diaphragm pacing studies that we all remember. Those were studies where we started out in a non-placebo controlled way. So we didn't use placebo, and it looked great. It was really an impressive effect that we perceived with these diaphragm pacing studies. And then came the placebo-controlled trials, and it turned out that it was actually harmful, it seemed. And these are repeated electrical stimulations of the really insertions of the phrenic nerves in the diaphragm. Very disappointing, certainly. I mean, because I think many of us who had seen some of the people who did so well when we didn't have a placebo control were disappointed to see that when it was compared to placebo, that it wasn't really an effect there. If that was from the surgeries themselves, or if it was from the repeated stimulation, I think it's not absolutely clear, but there is, I think, quite possibly it is from the stimulation that was harmful.
Yeah, and Björn, thanks for raising this. It's a great example of the need for placebo, but just to clarify, this was an example of using electrical stimulation to sort of compensate for a lost function. It wasn't an attempt to regenerate the nervous system in some way or to fix the underlying problem. So, and I think, Cliff, you touched on this too, we need to think differently about sort of electrical interventions that are designed to ameliorate symptoms or manifestations of the disease, as opposed to those that might be what we're all looking for, which is a therapy that actually changes the underlying biology and course of disease.
I just want to thank your comments. It's a local clinic here in the area is beginning to offer this electrical stimulation with a good website and marketing. So I thank you for the scientific comments to reiterate that these offerings have no scientific in the back. But again, also pointing out what we have talked before, the challenge that we have in our practices when a lot of hope is placed into these type of therapies with no placebo, no data, but a lot of good marketing, a lot of good environment, but there's no science behind it. So look at the price, the same thing of the stem cells. Now there's a recent clinic that is open and offering this. It could become popular in the communities through social media. Here the scientists have clearly stated there's no science in that, and be clear that even though it's offered and recommended by other patients, you have to be careful about what they tell you. There's no science yet in there.
So we talked about stem cells, and I want to ask someone in Dr. Bedlack's session asked about CRISPR, and we hear about antisense therapy. Are there any trials going on with genetic modifications, and how hopeful is that mode of therapy?
So I'm happy to start there. I think, and I want to actually, Patty, if I may, tie this into one of the questions in the chat box as well about, the cause of ALS, and people asking about genetic causes and environmental causes. And so I think one of the things to say is that we think at a general level, 3 things contribute to causing ALS: our genes, our environment, and age as we get older, right? We can't change getting older. We may not be able to change our genes, although maybe that's beginning to change. And the environmental stuff is sort of modifiable. But one of the important things to say is that it's probably the case that there isn't one single cause of ALS. And in different people, different things are probably responsible for causing disease. And our understanding of the genetic causes in 10 to 15% of people with ALS, and that's 10 to 15% of all people, not just those with the family history, means that we now know what the cause is in that subset, and we can begin to target that. And it's the idea behind, for example, an antisense oligonucleotide, and these are gene specific. So for the SOD1 gene, for the FAS gene, for the C9 gene, these are targeting the specific underlying genetic abnormality or a consequence of that genetic abnormality. And some of those are in very advanced phase testing. We're hopeful the next weeks, days, sometime very soon, we'll hear about the phase 3 results of the SOD1 antisense study. The C9 antisense in phase 1 is progressing. There's work being done in New York on the FAS antisense. And so I think we hold enormous hope that these are going to lead the path forward to begin to show us what an effective treatment for ALS looks like. And I know that this only targets a subset of people, but what I would say is that I think we will build more success upon initial success. And so if we have a real meaningful treatment for any form of this disease, this is going to teach us an enormous amount about how we get traction in other forms of disease. And just to answer the CRISPR question very quickly, I think it's not yet in ALS, at least not in humans. But I think this is coming to a theater near you, so to speak, but not quite yet. But other forms of gene therapy may come sooner. Viral vector mediated therapies will probably come sooner. So this is very relevant. And to say that from this technology, we're also learning about approaches to treat people with non-genetic forms of disease based on shared genetic risk that may not cause disease, but which may contribute to it. So I'll stop there.
If I can just add one point to what you were saying, and maybe you would comment more on this, Michael, but one of my discussions with patients, they're very scared when they're told they have a genetic version. And we talk about the treatments that are coming on. But some of the other data that you've been putting forward is in the future, if you have this genetic, we may have markers where we can identify the disease before it becomes symptomatic. And if the future holds that, and you put that in combination with therapies that can now treat the disease, be it the genetic or the sporadic, it's going to lead to a whole different frontier for therapies of ALS, where the disability becomes minimal in the future when we address it before it's symptomatic.
Yeah, absolutely. So to comment on that, James, and I'd raise this right up front, when we know the cause, and when we know the cause genetically, for example, we have the opportunity to identify people who carry that genetic cause who haven't yet developed ALS. And that's the opportunity for prevention. And that's the clinical trial that has recently started. It's called Atlas. And it's enrolling people with an SOD1 mutation who puts them at risk for disease, but they don't yet have it. And we're using a biomarker, and maybe we'll have time to talk about that, but that's a biomarker we've learned about from people participating in non-clinical trials. So we now have a biomarker that tells us when to give that gene therapy or that antisense oligonucleotide to somebody who's at genetic risk, with the hope of preventing it. And just to say, I think at some level, ALS is like cancer. If you catch it early, we have the greatest chance of a cure. Somebody asked about a cure in the chat box. I worry if we're coming to ALS when it's sort of metastasized, like cancer that's gone everywhere, it is so much more difficult to get under control and to actually meaningfully affect a treatment or a cure, if we can use that word. But if we can get in early before it gets a foothold, I think that gives us the greatest chance. And again, this is just for a subset of people with genetic disease now. But if that shows us that this is possible, then I think this opens up an enormous approach for how we might think about this in people with other genes. And as we learn about environmental exposures, environmental causes of ALS as well.
I just want to thank you, Michael, for the work you've done on this. You're a pioneer internationally, and it's with great pleasure that one patient that I have with SOD1 that I've now infused in the tofersen has been stable, and it's thanks to the work that you have put. And now that we have a preclinical study, your work is really hope, at least for me, and I guess for everybody, the work you've done. I just want to really thank you in a public venue, because your work has really given us a lot more hope, and we get into something that really works in front of my clinic. So a shout out to you for what you've done.
You're very kind. Thank you, Eduardo.
That's really exciting. That is so exciting and so hopeful. We did get some questions, and I want to make sure we have time to address the therapeutic potential for ibutylast, metformin, and AMX0035. Can we talk about those three therapies?
I'll start with the Butylast since I'm the PI on that one. So this is a drug that's coming out of Japan, where it has other uses in stroke, and it's being repurposed because it has neuroprotective qualities. It has gone through a small phase 2 trial in the US that had sort of, I would say, intriguing signal. On average, it didn't really show much, but there did seem to be a subset of patients that might benefit. So we are now doing a larger trial with the drug. This is a very classical design. So we have a high allocation for placebo. It's a 1-to-1, and we're going for really early patients. So it is a difficult trial to get into, again, with a high placebo rate, but it will, I think, answer the question very clearly whether or not ibutylast has a meaningful clinical benefit. Again, this first phase 2 trial is intriguing. Certainly makes me interested in studying this drug, which has a good safety profile, but it is far too early to say if it actually provides any benefit.
I can talk about the Amylyx. I mean, the phase 2 trial has been published, and in that study at 6 months, there's roughly a 25% slowing of progression. And when they look back at after 3 years, there's a 6.5 months extension of life. So as you can hear from Amylyx earlier, they're planning a second phase 3 study, but at the same time, as Dr. Bedlak mentioned, the FDA is reconsidering the data and see if they can put in some sort of alternative plan instead of just rejecting it outright. And the Canadian government is actually looking at it as well. So, the future is still kind of muddy as to what's going to happen next. But the phase 3 is actually, we just had an IM this week, so that study should be recruiting soon.
And a lot of people have questions about metformin and using it in ALS. And let me start with metformin's a complicated drug, and you really, again, should be discussing this with your neurologist. Metformin has been studied in a lot of different cases for ALS. When they used it in the SOD mouse, it did not provide benefit. Okay, where metformin may provide benefit is Dr. Benatar was talking earlier about the C9orf72 mutation, which we believe there is the gene that you can treat with an ASO and you may treat it, but there is the byproduct of the gene that you still have to address as a problem. So just correcting the genetic problem may not fully stop the disease because the byproduct may be there. The byproduct is something called RAN proteins in this particular C9 group. And metformin is known to reduce the production of these RAN proteins. So it's being studied in a very particular version. And when we use these C9 mice, that's where we see the benefit of metformin. It improves the mice behavior. That same diagram that Dr. Bedlack showed with the plasmapheresis of the CSF, we saw the same thing when we put them on metformin, that there was improvement in their movements. You would see that. The mice lived longer. But again, that was a very particular group that it was used for. And we are doing that in an open label study to verify that, in fact, in humans, it does reduce those RAN proteins. So it has potential, but it is not for everybody. It's particular for the C9 right now until we investigate it further.
Okay, thank you. We have a question in the chat about neuroplasticity. I understand that once lower motor neurons die, they can only be compensated by dendrite sprouting of adjacent neurons, like in polio patients, but how about upper motor neurons? Does anybody want to comment on this?
Yeah, I can jump in there. I was very interested early on in my career, especially about this kind of compensation, if you will, in ALS. And yeah, the peripheral nervous system, we'll start with that. So nerves in your arms and legs, they're quite plastic in a way, and they actually have tremendous compensatory capacity. And that's usually a good thing. So it's like a telephone cable. You have all these cables in there, and the cables contain individual telephone lines within them. If one of those lines goes out, in the case of the peripheral nerves, another line can pick up the function of the one that went out and keep everything in the muscle working. To kind of boil it down, simplify it a little bit. And that's called collateral sprouting, without getting into too many details, or compensatory collateral reinnervation is the medical term for that. It works well, maybe too well, because it can disguise disease for a long time. So it can actually, you can lose half of those telephone lines within that bundle, the motor neurons, before you start to get weak. So that's a bit of a problem, because it means that in terms of treatment, because it means the disease has been going on a long time before the patient may even notice that anything's wrong. So in other circumstances, of course, with injury from trauma or other things, it's a good thing, but not always a good thing in ALS, because it disguises the disease, although it does keep you functional longer, and that's a good thing. The central nervous system is a little bit more common. And by the way, we've been talking a lot about preventing disease, but at the same time, we're always thinking about ways to enhance this process of collateral reinnervation, and also just enhance neuronal recovery, as you got this balance between the nerve being damaged and trying to repair itself, going back and forth until the disease ultimately wins. If we could really enhance, supercharge compensation and repair, we might be able to fight the disease to a standstill. We don't have techniques for that right now. We're looking at that. Stem cell approaches are one of the things we hope would work, and maybe someday. We're not there yet in that regard, but that's compensation as a treatment strategy. We don't have a way to enhance that right now, but it does help you naturally. Now, in the central nervous system, it's a different kettle of fish, as you've alluded to. The neurons of the brain cells don't have the same kind of capacity, although they do have, in the spinal cord anyway, limited capacity to branch and to be able to make some compensation. And the brain also can reprogram itself within limits to be able to compensate for lost function. Unfortunately, that reprogramming works a lot better when you're dealing with cognitive function and speech and motor control and things like that. It doesn't work quite as well when you're dealing with the system that operates your muscles, although there may be something there. So that's a short answer. It's a great question, a very fascinating and complex topic, but we don't have treatment strategies yet directed at those things. But compensation as a strategy to fight the disease, we would love to see more of that, and we're thinking about it all the time.
If I can just add a little bit to that, and this is a little shout out to Dr. Locatelli and the group that where we've collaborated together on is, you mentioned Bulbar, but when you do these type of Bulbar interventions that have been started, and this is just exercise, just simple Bulbar exercises that are that have been established, it can promote some of these compensation systems. We don't know if it's promoting the plasticity, but it may be helping with this, and it can improve quality of life. And there's some data even about how FVCs and cough being improved for an extended period. So when you get to this upper motor neuron and this compensatory system and helping it, there's a lot of interventions that can be done that are very, very simple, that just doing it twice a day can make a huge difference in the disease, in the impact of the disease.
There's also, I guess, a lot that we don't know when function is lost about if it's due to nerve cells not functioning or if nerve cells are truly dead. Again, that is the process that we do know from pathology, that eventually these nerve cells are dead, they're gone. But we think that for a while prior to their death, they're probably not working right. And again, how long is that time period? How will that be a period we can intervene and kind of bring things back to normal before, when they're injured but not dead? Certainly something that is a hopeful thought that there might be function there that we can recover for people.
Yeah, I don't want to geek out too much, but since you brought it up, I will say that going back to the Riluzole data, some of us were doing this technique, motor unit number estimation, which counts the number of those telephone lines that are still active within the cable that is the peripheral nerve. We did studies. I did one with the original Riluzole study. Tells you I'm dating myself now because that was 1995. But in any case, what we found was that when Riluzole was administered within the first 2 to 3 months, the number of motor neurons increased over 8 to 12 weeks by about 10 to 20%, some cases 30%, and then it kind of leveled off, and then the disease progression sort of began again. And the hypothesis we had, we couldn't really prove it, but we were theorizing exactly what you said, that there are these neurons that are comatose. They're not dead. To quote Monty Python, they were not dead yet. They were still there, and they could be resuscitated. And that we think maybe the Riluzole, one of its functions is to decrease the excitotoxic attack on those motor neurons enough that they can revive and come back into operation. That was our theory. We never really were able to prove it, but it was intriguing. So I think, yes, a lot of the drugs that we're seeing now may work that way. They may bring back these motor neurons that are on the brink and pull them back into operation. So then that's very exciting.
We only have a few minutes left, and there's so many good questions, and I hate to not have the time to get to all of them. But I guess there is kind of a big picture question. One of the questions earlier in the chat was, are we going to cure ALS? And this most recent one, any comments on treatment progress in other neurological diseases? And is there any exciting fronts going on in ALS research? And anyone comment on any of those questions?
So I guess I can comment just a little bit on the related disorders, Patty. So, people with ALS, we have a challenge because ALS is a rare disease, and so it's hard to move therapies forward. But there are related motor neuron diseases, and there may well be people in this group who have primary lateral sclerosis, PLS, or progressive muscular atrophy, PMA, or even FTD, frontotemporal dementia, which can be a related disorder. And that's just the sort of the narrow set of related disorders. There's a broader set of related disorders. And the challenge is that those are even rarer. There are almost never clinical trials specifically in those populations. And typically patients with those related diseases get excluded from clinical trials. And so therapy development is incrementally more difficult. And so I think for me, that raises the ante, so to speak, that whenever we're doing observational studies, genetic studies, environmental studies, biomarker studies, it's critically important that we cast a broader net and include people with those other diseases to understand the ways in which they're similar and differ. And that may help us as therapies come over the horizon for ALS, for us to have a better understanding of whether there's a hope that they can be effective for people with related disorders, or how we might go about figuring out if they are going to be helpful in people with those related diseases. So I think this is an area we don't talk enough about. I mean, ALS is the core of what we often talk about, but we should remember ALS, I think, for all of us encompasses a broader group of related diseases, and that's absolutely at the core of the group of diseases that we're all trying to study and better understand.
I would say that from a layman's perspective, we have a couple of other motor nerve problems where we've done very well. We have the spinal muscular atrophy, which is now a disease that we have an effective therapy. It's these kind of antisense oligonucleotides that we touched on for certain forms of ALS that has changed the game there. Now there's even new generations of drugs that are tremendously effective for that disease. Again, it's a kind of the ALS of a young child, or at least a child. So it's a different disease. Multifocal motor neuropathy is another disease that many of us also think about. This is an inflammatory muscle disease. It's not ALS again, but it's also a disease that we successfully treat in the vast majority of people. So again, certainly there are other disorders of the motor nerve system that we have effective therapies for already.
In my thought on finding the cure to something that has many diseases inside, I also think that what we're going to see first is that we're going to have a cocktail of things that are going to help. Just maybe the one thing, maybe an antigenetic treatment, but there will be other things that will be neuroprotective, other things that will help with respiratory function. So because there's a number of things that we treat, and it's just not one disorder. Many of them are genetic with different genes. We will have to have a set of tools that we're going to use, multiple medications maybe and treatments that will be quasi the cure, and if we prolong it long enough and we allow them to have a quality of life, it will be a stage in which there will be many treatments, just not one single cure, because it's not one single disease after all.
Yeah, and I think that's one of the real successes of the AMX product that we don't talk a lot about with its future. It's a combination product. ALS may have multiple pathways that are involved. And we've always traditionally said this disease process is involved in ALS. This blocks that disease process, so it should work. And then it doesn't work in the human trials because everybody has their own ALS course. And I agree with the inclusion of all these patients in there, but we need to understand their disease, because ultimately it's going to go back to the meeting that all of us was at, 10, 15 years ago, when we talked about a kink in the armor. That was Riluzole. And then Radicava as a kink. And we'll see one or two more. And eventually we'll get to a treatment that is going to attack all levels of the disease, but it's going to take one incremental step at a time. And we're getting there. And AMX looks like, the data we've seen so far looks like it's clearly the next step.
I wish we had another hour or two to get through everybody's questions. I want to thank everybody for submitting your questions. I'm sorry if we didn't get to your question. We did the best we could, and we had even more that were submitted in advance. But I would like to personally thank every single one of our panelists. Thank you for your dedication, your hard work, your commitment. At this point, I'd like to turn it over to Dr. Gooch for closing remarks, and then as for closing remarks for the conference. So, Dr. Gooch, what are your final thoughts as we close up this panel?
You're muted.
Oh, we got to take you off mute.
Boy, that happens 5 times a day. So I want to thank everybody on the panel for all their great contributions. It is a great conversation, a great group of minds here. But I really want to speak now directly to the patients and their families who are on the line here with us, for whom this conference is being held. This has been a tough year. It's been a tough year for many of you who may have been diagnosed during the COVID pandemic with ALS. Maybe you had ALS prior to that time. Many people in the United States have suffered the loss of a loved one or have seen a loved one fall ill from COVID. 600,000 plus people dead from that disease. So a very tough year medically for the US, but especially tough if you also have ALS and you are trying to deal with COVID and restrictions and social distancing at a time when you need all the support that you can possibly get for your disease. And, I know that many of you may also be feeling lost in the shuffle, that, there's all this attention on COVID now, and what about ALS? But let me reassure you, you are not lost. There was a question in the chat about research in ALS and what's happened during the COVID pandemic. And I will tell you that in our center, and I know it's true of all the other centers as well, that we have been very dedicated about forging ahead despite the COVID pandemic. There was a brief slowdown in the beginning of the pandemic last year when there were shutdowns that happened and patients themselves didn't want to come in. That lasted only a couple of months, and then our teams were back in the office, back in the clinic, back in the lab, bringing patients back in, and you, the patients, were coming back in. So although COVID has had a lot of impacts, I think in terms of ALS clinical research, we have seen things forge ahead with a slight hitch in the very beginning and then a pickup. And it's been remarkable, the dedication of the teams and the patients and their families to continue to be involved in research and to push the ball forward. I also want to just comment on the fact that COVID itself has demonstrated something I think remarkable that we need to be reminded of from time to time, especially in terms of ALS. I'm sorry, I'm getting a bit of feedback. So if everybody could mute their microphones, please. I think COVID has actually demonstrated something very important that's very relevant for ALS research too. It's really, and I think the media has not put enough attention on this, it is truly miraculous that within a period of about 12 months, we were able to develop and deploy a vaccine that was highly effective against the COVID pandemic with a really minimal side effect profile. Typically, vaccine development is a 10 to 20 year timeline. This was an international crisis and huge resources were thrown at it. And lo and behold, within a matter of months, we have not one, but several effective vaccines that are working very well, using, by the way, for the most part, new technologies, RNA-based vaccines. And what this shows is that brilliant minds, when combined with the appropriate resources, truly can achieve miracles. And you say, well, geez, that's great, Dr. Gooch, but what about ALS research? I mean, that's what I'm interested in. That's me. That's the box that I'm in right now. What about that? Well, I've been doing this now for over 25 years. Some other people on the panel have also been doing ALS research for a similar time frame. And I've seen ups and downs over those 25 years. This past year has actually been a year, past 2 years has been an era of excitement and also progress in ALS research. A lot of discussion has been held about Amylex as being a drug that has been shown to work and is coming. And the pipeline behind it is filling up. At the same time, we are in the field of ALS research, actually reworking how research is done in serious diseases through the Healy platform, which is using all these innovative designs to speed things up and make it simpler and faster to find the answer. Does this drug work? Does that drug work? Does the other drug work? And I can just tell you, as mentioned before, but it's important for you to know, there have never been more ALS studies being done in humans or researchers around the globe working on ALS than there are right now this second. It is happening. There are people who are spending their entire careers focusing on how do we cure ALS, more so than ever before in the history of the world. We've never had this much focus on it. So that's very encouraging. So I want you to take heart, and I want you to know this. We are with you. We are fighting for you at your side. And it's not just us in the medical community and the research community. It's your family. It's your friends. It's your advocates, the ALS Association and other organizations that are focused on curing ALS. It's pharma and other companies who, yes, while they want to make money, there are people in those companies doing this research not because of the money. They're doing it because they want to cure this dread disease. And you, the patients, you, the families, you are our inspiration. Other people have talked about this earlier today. You are why we are doing the work that we do every day. And when we see your courage, and when we see your fighting spirit, and when we see the way that you're dealing with such grace with your very difficult circumstances, it inspires us, it blows us away, and it makes us want to work all that much harder. So I'll leave you with this thought, and I speak for everyone, every doctor, every medical professional, everyone for also who has talked to you today. We promise you, together with you, we will not stop working. We will not stop fighting. We will not stop trying everything we can possibly do until we end ALS and wipe it from the face of planet Earth. That's our pledge to you. We are behind you. Take heart. We're going to push. We're going to make progress, and we're going to get there. So I'll end there.
Marixa, can you be there? Okay.
Yes. Okay. So I am Marixa Salgado, your Regional Program Director for Central Florida East with the ALS Association Florida Chapter. As we close this amazing 8th annual Hope and Help Symposium, we want to congratulate all our award winners today and thank them once again for all the support they give us year after year. I want to thank our panels and Dr. Gooch for the beautiful words that you just said to end our day. Our agenda is usually planned based on the feedback we receive on the surveys you fill out. In order to continue to make this a successful event, we will be sending out a survey link in the next couple of days. Please take the time to complete it, as your responses will guide us in continuing to make the Hope and Help Symposium an annual event that meets your expectations. If you have not had a chance to visit the clinic booths located in the expo or any of our sponsors, please do so now, as they will be there until 5:30. Most sessions today were recorded. If you missed anything or feel like you want to look at a session again, please feel free to do so. On behalf of the ALS Association Florida Chapter, I want to thank all of our sponsors for standing with us and bringing you so much important and needed information and opportunity to speak with them. They will be at their virtual tables until 5:30. If you have not had a chance to visit them, please do so now. The gamification winner will be announced at 5:30 by the Director of Care Services, Jessica Collins. We would also like to thank the teams in the Learning Lab that have been working all day to answer any questions you may have on how to, from durable medical equipment, transportation, respiratory needs, and communication, to dietary, physical therapy, and occupational therapy. They will also be available until 5:30, so please stop by if you haven't had a chance. I want to thank all of the persons living with ALS, caregivers and family members, as well as those that have a connection to ALS that attended today. We know it was a long day, but we hope that the information and speakers we brought you today answered some questions that shed light on your ALS journey. Lastly, I want to thank the ALS Association Florida Chapter staff for all the hard teamwork that went into this event, as well as those from the ALS Association that attended from our national office and other chapters across the nation. The team at the ALS Association Florida Chapter would not be able to do all that we do without the leadership of our President and CEO, Ray Carson. Thank you for your support every day. In the last 2 years, we have learned how to continue to deliver services to you in a different way. What has not changed is the passion and commitment we have for the families we serve and the jobs we do. While we hope to make this an in-person event next year, the safety of the families we serve and our staff is always in the forefront of our decisions. Remember, until there is a cure, there is care. Thank you.